So if there's a family history of breast cancer, your starting mammogram age goes down to 10 years younger than the youngest person diagnosed in the family.
Because you want to catch it earlier.
Mm-hmm.
Interesting.
So if mom had breast cancer at 40, then you would start doing some type of screening for women at age 30.
Hello, welcome to the Dr. Gill Show. This is where we talk about medical matters that matter to you. My guest today is Dr. Ann Petersen. Welcome to the show, Ann.
Thank you.
Ann is my friend. She is a board-certified general surgeon, and she has a special interest in treatment of diseases of the breast.
You got it.
Breast is a loaded topic. The breast is what makes us mammals, mammary. So you'd think it's just an organ of nutrition, but it's an organ of womanhood, health, sensuality, self-worth. It's a very loaded topic, wouldn't you think?
I do. I think it differs a little bit culture to culture, but absolutely in America. Breast is a defining culture of gender roles.
Yeah, and we've had a plastic surgeon here on earlier podcasts, and it always seems like the grass is always greener. Small-breasted women want larger, larger-breasted women want to be smaller. There's almost no Goldilocks, just right.
I don't know. Yeah, maybe. I guess in the world of, and this just sounds crazy, but in a world where we're just talking about cancer is what I deal with most of the time.
Right.
Most of them just want them to be healthy.
Be healthy, that's right. And we're going to be talking about breast cancer today, and I can't think of a better person to discuss this subject with. I do surgeries in room 6, and right next to me in room 7, Ann is frequently doing surgery, treating women with breast disease, primarily breast cancer. And Ann has these gadgets. I don't even know what to call them. Gamma ray counters, dyes, needles, localizations. I was in there the other day, and you had this spread with all these, it looked like finger paints, all these different color paints. I guess you were labeling various specimens, various colors, and we'll get to that in a minute. I'm just fascinated by what you do and all this cutting edge stuff. So, Ann, you are a board-certified general surgeon. You did your residency in Nebraska, but you were also born and raised in San Francisco and Los Angeles.
Yeah.
So, how did a West Coast California woman end up going to medical school and training in the Midwest?
Well, when I graduated from high school and went to college, I was mostly just terrified about money, and so I went, my brother was fortunate and went to the Naval Academy. So that set the standard pretty high because he got paid $1,200 a year to go to school.
In Annapolis?
At Annapolis, they pay you. So
hey, a stipend.
Yeah, I think you end up paying your total computer fees. So the entire cost of college is $2,000. And then by the time you finish your first 3 years, you're actually getting paid to be there. So that set the bar pretty high to figure out how much money my college education was going to cost. Wow. So I applied early entry to Whittier College, a small college in Southern California, and I received a 3/4 scholarship. And so that sort of made it affordable. So
sure,
that's where I went. But I was ready to spread my wings a little bit. And so I only applied to medical school out of state. Because I wanted to get that opportunity, and medical school was going to cost a lot of money no matter how you did it.
Sure.
So I interviewed at several places, was accepted at a few, but at St. Louis University, the dean of medical students knew everybody's name. If you walked down the hall, 400 med students, he knew who everyone was. It just felt like the right place. So that's where I went. So I got out to St. Louis, and then from there, same thing with residency, just found the place that was the right fit. And Nebraska was it.
And now you've been a general surgeon for a number of years. I think you were already practicing for 11 years before you came to this area.
I was.
And clearly you're money savvy because you actually spent the time to go to night school to get an MBA as well.
Maybe money savvy, maybe weirdo.
No,
I get
that's fine.
bored easily, so not busy enough. Go to school at night.
Sometimes people can't stop studying, and then you'll go for the MPH, and then the JD. You know,
I did the AACP, that American Association of Physician Executives, became a certified physician executive.
Oh, that too. So even more letters.
So then I recently did City of Hope training for genetic testing. Completed their courses for certification for genetics.
Oh my goodness! What a powerhouse! I tell you what, I interview some of the smartest people in the world. It's just amazing. So our audience may not know that almost all breast surgery in the United States is done by surgeons trained in general surgery. It's like a real large chunk of general surgery. When did you decide to really focus just on breast health and breast cancer?
Really, when I moved to Columbia.
About 3 years ago, was that?
6.5.
It's been 6 years already.
Yeah.
My goodness, 6 years ago.
Yeah.
When I was an OBGYN resident, one of our rotations in breast health was with a general surgeon who did only breast health. He has passed away. His name is Stanley Edikin. Stanley worked 9 to 5. He was always dressed perfectly, never cracked a sweat. And we learned an awful lot. The OBGYN residents learned a lot about breast health from Stanley. And it seemed like a great service, yet he's not taking trauma call and answering the helicopter when it comes in with a trauma or something like that. So it seems like a very interesting kind of niche of work. Now, you still take general surgery call at nights and whatnot for your group, don't you?
I do, nights and weekends.
So you could still do any kind of general surgery. So you were drawn to treating breast health, and we know breast cancer is a big deal. It's more common in the developed nations. It seems to be much more common in Europe and North America and even Australia. And if I'm reading this correctly, apparently the lowest incidence of breast cancer worldwide is in South Central Asia and Africa. Do you have any thoughts about that? Is this a disease of the modern world, or do we live longer than they do in Africa? What are your thoughts on that? That's really fascinating and concerning.
Yeah, well, we believe that we can prove that about 10% of all breast cancers have a genetic component. And there are those who believe that probably up to 30% of breast cancers are going to have a genetic component.
So mutation. Now, we have these recognized mutations, the most famous being BRCA1 and 2, but there are others. Well, clearly there's 20, 30,000 genes. We don't know them all yet. So there may be others. So you're saying maybe up to 30%, maybe a third are individuals that are predisposed to these things.
Yeah, and probably that's carried in our Caucasian communities a bit more than in our Asian and African American communities.
Because it certainly seems to be even a little higher with Eastern European or Ashkenazi Jewish populations. So there is that, just the genetic risk factor. And then we've got the where you live risk factor.
And the interesting thing about genetics is most all of the genetic work has really just been done in the European communities.
So there's some selection bias right there.
Just of the testing. We've not really fully explored much of the African genetics. That just hasn't been the population that's been tested. So who knows, as we add on those other genomes and have those larger pictures of DNA, what else is there, since most of the research has been done on European.
Sure. I know
heritage.
Pharmaceuticals, even drugs for women, have been tested on white men for so long. Now, in the United States, we have over 250,000 new cases of breast cancer a year. About 1% of them are in men. People may not know that. I also read that the death rate from breast cancer in the United States is about 42,000 women, which looks to me about maybe that's a sixth, or maybe 1 out of 6 women diagnosed with breast cancer will die of the disease. Is that about right?
I honestly don't know the answer to that.
Okay.
Our longevity has gotten up. Most of the time we're starting to do where we are more likely to die from other causes but have breast cancer. We don't necessarily die of breast cancer. Now, there are definitely many women who do, but our treatment has improved so that lung cancer still remains the leading cause of death of cancer from women. But breast cancer is the leading cancer diagnosis in women other than skin cancer.
Other than skin cancer. Interesting. So this is a number I'd like you to help me with. One of the cancer societies says that a woman here in the United States has a 1 in 8 lifetime risk of getting breast cancer. But isn't that somewhat misleading or misleading or maybe scarier than it should be? Should you say that if you live long enough, it's 1 in 8? Or is it really 1 in 8? If a girl is born in the United States, she has a 1 in 8 chance of getting breast cancer. If you
live over the age of 45, yeah.
If you live over the age of 45.
Which most women in the United States will.
Now. Yeah, and I understand
it's
that.
It's really 1 in 8.
It is 1 in 8.
13%, yep.
Wow, it's like a ticking time bomb. Now, as a man, I believe if I live long enough, I have a 70% chance of getting prostate cancer, which is a little scary. Fortunately, it tends to be a slower, in general, more often a slower, less aggressive form of cancer. But boy, we have these time bombs in our bodies, our lungs, our colons, our pancreas. These are hot spots, aren't they?
Yeah.
Wow. Every day is precious, isn't it? Now, let's talk a little bit more about breast cancer. Breast cancer goes up with age, doesn't it?
Yeah.
And it seems to be
second highest risk factor.
Second highest risk factor is age. And in fact, I got this very
look at you.
Common little graph, and I'm going to put it up to the camera here. And if you look at this line plotted with a woman's age and a man's age too, it just goes up and up and up. And I put in pink here the line of menopause, when typically female hormones crash or go way down, yet the breast cancer still keeps going up and up and up. Now down here, it's hard to see. There's a little tiny line that keeps going up with age. That is the men, the 1% or so of men. So age is clearly a risk factor, and there's nothing we can do about age. You said it was the second largest factor. What's the first?
Being female.
Oh, that's like a trick board question. There you go. And being female. I like that. Now, there are other risk factors for breast cancer. Girls who get their menses early or women who have late menopause seem to have a slightly higher risk. Maybe we could talk a little bit about dense breasts. Some women, you do a mammogram and they're just dense. They are thick. They impede the x-rays. And I know there's been a lot of controversy about that. And I'd like to visit that for a little bit when we come back to these things and we unpack them a little bit. Obviously, if a woman's had a breast cancer already, there's a higher chance she might get another one. Is that?
A little bit depends on that. So it depends on age of diagnosis.
Okay.
And some of her risk factors. So in general, a woman diagnosed with breast cancer over the age of 65, actually her risk of developing a whole new second breast cancer is going to be less than the average population at that age.
At that age.
But a young woman diagnosed with a breast cancer is going to have a higher risk of developing a whole new breast cancer unrelated to the first.
Well, a different type or the other side or whatnot.
Yep.
Interesting. And I think having a precancerous lesion of the breast also is a risk factor as well.
Yes.
So it runs in families, and a lot of these genetic mutations, let's call them, BRCA1 and 2 being more famous. I'm sure you could rattle off half a dozen more.
Obesity,
our weight can affect it. I think previous radiation.
Radiation. So radiation under the age of 18 to the chest. So we usually do that for things like Hodgkin's lymphoma, certain types of thyroid, some sarcomas. Those lifetime risks of breast cancer are similar to having a BRCA mutation, 40% lifetime risk.
Whoa, so you need to consider that when you're getting treated for some other problem.
If that were to happen, then those women are usually told and informed, and then they follow up under very close surveillance as they get older.
Interesting. And one little historical footnote, that I had to learn all this in GYN. There were still girls that had been born to mothers who had taken DES, diethylstilbestrol, to try to prevent miscarriages, and they have these abnormalities, development of the uterus. Thank goodness that drug is in the waste bin of history, and we don't have to deal with it. But theoretically, that's something you might hear about. But I don't think anybody's taken DES in a long time.
Yeah.
Wow. Now, other risks for breast cancer. Somewhere I read that low amounts of exercise. Does exercise offer some protective benefit?
It does. The data shows 30 minutes, 5 days a week is the baseline of increased protected benefit. Reduces the lifetime risk of breast cancer by several percentage points. And that curve never goes down. And what that means is more continues to have benefit. So if you can exercise complete. So if you exercise 60 minutes a day, 7 days a week, your risk reduction is even greater. And the more you can do, it continues to go down. And that's completely unrelated to your weight, to your other risk factors. It's completely independent.
I won't go into the statistics, how you partition variance, but that sounds like something you probably hang your hat on. Apparently, having a pregnancy when a woman has babies late in life after age 30, that might put her at slightly higher risk?
Yes and no. So having babies early helps to sort of lower that risk. But once your first baby takes place after age 35, and we usually say after age 40, you no longer sort of get any extra protection. It's the same as though never having a baby at all.
I see.
So a late pregnancy doesn't make you higher risk than somebody who didn't have children.
It's the lateness, not necessarily that having had that pregnancy. Now, for years, alcohol was touted as having health benefits, heart benefits, and whatnot. But it seems over the recent years, and tell me if I'm wrong, that people are saying there may be almost no benefit. Alcohol may be harmful at any dose. What are your thoughts on that?
Oh, I don't want to have thoughts on that.
Yeah, like having a glass of wine. Thank you very much.
Yes. And yet, everyone tells us that premenopausal women for cancer risk can have about 3 appropriate sized drinks a week.
Okay.
That's 5 ounces of wine 3 days a week.
Sounds moderate.
Postmenopausal women are not supposed to have any, or have 1 a week, which seems rude and unfair.
It seems unfair. So there's a stratified risk. Interesting. And once again,
I don't know. That's what I don't know.
Well, and let me explain to our audience, these statistics, these risk factors, or we're called hazard ratios, it gets interesting, are derived from very large data sets and their associations. No one has done a study where a group of 65-year-old women had the drink and then they did not.
I would sign up for can I have a glass of wine with dinner every night?
Yeah, I don't want to be in a blinded sample. So these are mathematically derived numbers from models. So we don't want to infer firm causality, but these are trends that seem to come out in the models.
Yes.
Now, something that's very controversial is, do birth control pills increase risk of cancer? Most birth control pills have a synthetic estrogen and a synthetic progestin, or progesterone-like compound. And we know these hormones are different from the natural estrogen and progesterone the bodies make. And I was always taught that birth control pills really were neutral, did not affect a woman's long-term risk of breast cancer. Now, you know this better than I. And do you have any thoughts on that? Can you help me out a little bit more with birth control pills and breast cancer risk?
I think it is so that the textbook answer in the breast cancer world is for women at increased risk of breast cancer over the age of 35, staying on birth control pills likely adds a risk of about 1 to 2 percentage points. That's a very low risk. It's very small. And it's only once you get closer and closer to your menopausal age, so over 35. And all of that data was really generated on older forms of birth control, which you know carried much higher doses of the hormones.
Right.
So what do we really know? Well, at 35, for most women trying to figure out their lives, family planning is also incredibly important, as is mental health, as is financial health, as is the ability to perhaps control your body and determine when you bleed or how much you bleed, and all of the parts of life that go along with that. So it's like almost everything else in life, it's a balancing act.
It's a balancing act, but it is not, the take-home message is not particularly harmful.
It's a small, if anything. So, and in fact, in BRCA carriers, we don't recommend stopping birth control because, as you know, one of its key points is it lowers the risk of ovarian cancer.
We have to consider the whole and all-cause mortality.
Still balancing. It's all about balance.
Yeah. Now estrogen has gotten a bad rap over the years. You just think, well, some breast cancers are fueled by estrogen, so estrogen must be bad. But some big studies have come out, and I know the American Cancer Society, NAMS, North American Menopause Society, and whatnot, are pretty clear that pure estrogen does not seem to increase breast cancer risk in an average risk population. Would you agree with that?
Absolutely.
Am I reading that right?
Not only that, but it's been shown to increase overall survival for women in an average risk population.
So
better bone health, better heart health,
right.
Better overall health.
Right. So once again, complicated subject. I don't want to go spend too much time on it. So estrogen itself is not necessarily a culprit when we start mixing it with other medications and perhaps in other high-risk populations. That's where things might get more complicated.
Yeah.
So let's not broad brush estrogen is a bad thing. It needs to be seen in context. And another thing, I don't think we had much data before 2020. We had little case studies here and there. Oncologists used to recommend that women who had breast cancer not get pregnant. I believe that was common recommendation, and yet some women would get pregnant, and there were little case series here and there. I think the first one I read was from the United Kingdom, but I think a larger meta-analysis came out in 2020 and showed that women who had breast cancer and then got pregnant seem to do pretty good. Can you help me with that?
Yeah, absolutely. They can go on to have very healthy pregnancies, very healthy babies, and not put themselves at risk of relapse, recurrence, danger from their own disease.
Right.
All with, the caveat that we're not actively undergoing chemotherapy or radiation or certain treatments. But yes, absolutely. There's many women have had very successful pregnancies after having breast cancer treatment.
And it did not necessarily fire up an indolent or smoldering breast cancer.
Correct.
Yeah. The knee-jerk reaction in years past was, well, if your breast cancer cells are susceptible to estrogen and progesterone, and pregnancy results in high levels of estrogen and progesterone, can't be good. But that's a very naive view of cancer, isn't it?
It shows we really don't know all that much about cancer and hormones, or as much as we wish we did.
Yeah, and pregnancy is associated with changes in the immune system, some things suppressed, maybe surveillance up. And something really fascinating is now you have fetal DNA. The baby just doesn't stay in the uterus, it leaks out. into the woman, and the fetal
Babies.
cells are interacting in fascinating ways. Just fascinating. That as a reproductive specialist, that just fascinates the bejesus out of me.
Terrifies me.
Arthritis, Graves' disease, all kinds of things, maybe due to the fetus attacking the woman. Interesting. So, let's talk about how does a woman, we're going to talk about breast cancer specifically. How does a woman screen herself for breast cancer? I know that we've recommended self-exams for many, many years, and guys just feel your junk every month for lumps and bumps and whatnot. What do you recommend women do to do some basic screening at home? Or wherever they choose, on their own, let's say. You can do it in a hotel room, I guess.
So we would recommend doing a self-breast exam. If women,
but once a month?
Once a month.
In the shower when it's all slippery and soapy?
Slippery is usually the best.
Okay.
We usually recommend that be done about a week after menstruation or a week after a woman's period if she's still having periods.
So timing can matter. Because other times during the month, high estrogen, you can have little glands that are lumpier and bumpier.
Yeah, little cysts, little glands, little other things that change, tenderness. And so about a week after your cycle or after, period, then that's the right time to sort of do that.
Check in and know because some people have a little lymph node here and there, and that's just how they're built, and that's your lymph node, and it's stable, so that's important to know oneself, isn't it?
Yeah.
So, is there anything, and obviously, maybe look in the mirror, look for redness, skin changes.
Yeah, if you're somebody who thinks about it and pays attention, then if you're looking in the mirror, not only that, but you should look with both your arms down as well as raising your arms up.
How about this hands on the hip, flex the pecs? Is that part of it? Or?
Probably not so much.
Oh, not so much. And another sign that I think is worrisome is if most women, the nipple comes out. Some women have innies. You got outies, innies, the belly button. Some women have inverted nipples, but if a nipple becomes inverted, that's something they should come to you to see about?
They should. If a nipple becomes inverted, myself, their primary care physician, their GYN, same thing if they start noticing discharge coming from a nipple, especially if it's bloody.
Bloody is the worst kind. Gotcha. Now, mammogram. Mammogram is an x-ray of the breast, special machine. I think the techs are getting better at not hurting with the sandwiching of the breast tissue. There's a lot of controversy about mammograms, Ann, and I'd like you to help me with this. I also believe some of the controversy comes from different countries where the medical care is paid for differently, and they have different tolerances for what are called false positives and potentially unnecessary procedures, and they mix that in with what we would hope would be would be misdiagnoses or false negatives. So tell me, but please help me. This is a big topic. Maybe you can give us an executive summary about what you think about mammograms and what is their role in breast cancer screening.
I think mammograms are wonderful.
All right, there you go. All right. Next, no, please help, flesh that out, unpack that, like they say.
So mammograms are our least expensive, least invasive way of catching the majority of breast cancer cases early.
Okay, period. Okay.
In the United States, and just like anywhere else, not just in the United States, mammograms and the quality of the mammogram has a little bit to depend on the equipment.
Okay.
And a lot to depend on the institution, the volume that they do, and the quality of the read of the radiologist.
So this is experience where experience matters.
Experience matters in mammogram. So when you have a place, every center that it is accredited has their data where they know what we call the callback rate. So when you get a mammogram and you're told, this looks a little funny, you need to come back in and see us. Mammogram callback rate should be 4% or less. Of that callback rate, we expect there to be an almost 50% need for maybe a biopsy or an intervention, because the only people being called back are really those who end up having something that's a little funny looking.
So most of these are what we call true positives, and you want about half of them to be really positive.
Yep.
Gotcha.
So when you end up, there are centers where maybe they do, mammograms in addition to doing a whole lot of other things all day long.
Right.
And they may have a mammogram callback rate that's 10%. There's some places as high as 20%. And that's where people start to get into a little bit of distress. Something gets followed for quite a long time. Maybe something's totally fine, but somebody just, better safe than sorry. Let's just take another look at that.
And it's not a benign thing, because now the woman is awake all night and worrying, and her spouse or whomever, and they're scared to death.
And a heightened concern, and maybe getting imaging every 6 months.
Right.
For something that perhaps a more experienced radiologist would say, oh, no, that's nothing.
They'd be more comfortable letting that go.
Yeah. Or maybe, before 3D mammograms have become almost standard now. But just, until about a year ago, they cost extra money that women had to pay extra to get the 3D mammogram.
Has that stopped? Is 3D the same price now?
Yes.
Thank goodness.
And that made a huge difference on how comfortable somebody felt looking at the pictures and saying for sure, oh yeah, this is nothing to worry about, versus I don't want to say this is nothing to worry about. Let's just get another picture.
Gotcha.
So for that reason, mammograms are great. Only about 1 to 3% of breast cancers cannot be seen on mammogram.
Okay, I thought it was as high as 15%. I was wrong. So it's a small minority are missed.
On our digital 3D mammograms,
Gotcha.
Current technology era,
I love it.
it's really quite small that we don't pick up on mammogram. Now, we can catch them earlier on other imaging devices, but we see most of them on mammogram.
So the progress continues to be made in imaging. And I know they say this frequently, and the dose of x-rays is awfully low. Isn't that correct?
Quite small.
So you don't have to worry about, oh my God, I'm going to get a breast cancer from all these mammograms.
There's still all kinds of articles on the internet telling you that getting your mammogram increases your risk of breast cancer, and those suggesting perhaps doing MRIs instead of mammograms.
The MRIs, they're expensive.
They're expensive.
They're really expensive.
An MRI of the breast requires IV contrast.
So they put a contrast in the vein. It circulates to the blood vessels, and then those are seen better. Yes.
And the earlier forms of gadolinium cause some accumulation in the brain.
Oh my goodness. I have some gadolinium in my shoulder today.
Yeah, the newer forms of gadolinium are not expected, but where's the data of what an annual MRI with gadolinium does to you after 30 years?
Wow.
We don't have that data.
We don't know. Oh my goodness. Now,
maybe I shouldn't bring that up.
No, dude, no. I hear you. Preach the controversy. Let's talk about it. Makes for good discussions. So the next controversy with mammograms is, when do you start? So let me start with the average woman, no family history, just going about her life, doesn't feel a lump or a bump, wants to get screened. I know they tell us to get our colonoscopy at 50. Maybe they've bumped it down to 45 now. What is the current recommendation for mammograms in your average, let's say, American woman?
Recommendations by breast surgeons. My recommendation, 40, and then every year thereafter.
Now, I expect, since for me it would be like endometriosis and fibroids. I see them all day, and I want to catch them early before they cause problems. So, is the average? Is there a American Cancer Society recommendation at 40 or 45 it'll be a little different.
It's going to start at 40 to 45, and then like the American Health Institute or some such thing is then going to say every 2 years.
Okay, and obviously these are cost-benefit analyses.
They're looking at mortality.
Gotcha. And also resources. I mean, if you've only got one machine in a community and you can fit everybody in every 2 years, and I know recommendations are different in Canada, where it's a very different system of payment, and machines might be, the number are regulated. I know the MRIs are regulated, how many they can have and whatnot. So when a person goes on the internet and Googles this, they might see different recommendations in different countries.
Yeah.
But if it was somebody you cared about, you would recommend a woman start at age 40.
Correct.
All right. So let's say we have a woman in her 30s, no real family history of breast cancer. She feels a lump or a bump. It comes to a family doctor. Let's say goes to the radiologist. They see something suspicious. Do the radiologists do the first biopsies frequently, or would you do the first biopsy?
Usually the radiologist does. So if a woman is age 35 and older, she'll get a mammogram and usually an ultrasound if she feels something.
So if they see something on the mammogram, will they do an ultrasound immediately right there?
Sometimes.
Or they'll call back for that?
Depends on how available the day is.
What does the ultrasound add in addition or on top of the mammogram?
Adds a better sense of size. If something looks suspicious, at most breast centers, like here at Boone, they will then automatically look in the armpit area to look at lymph nodes as well. With the ultrasound? I'm learning so much. So that's part. So if they say, hey, you need an ultrasound, a woman shouldn't get nervous. That's just part of the evaluation we can
process.
see an abnormality on mammogram, and then when we look on ultrasound, it's a cyst. And a cyst is usually completely benign. We don't even need to put a needle in it. If we can see that it's completely regular as a cyst, nothing more needs to be done.
Fantastic. Now, tell me if I'm wrong, in women who have, or I guess men too, who have family histories of breast cancer, I assume it'd be reasonable to do genetic testing for these more common mutations?
Depends on the family history and the member.
I see.
So if there's a family history of breast cancer, your starting mammogram age goes down to 10 years younger than the youngest person diagnosed in the family. Because you want to catch it earlier. Interesting. So if mom had breast cancer at 40, then you would start doing some type of screening for women at age 30. Now, we don't do screening mammograms usually much before age 30. So if mom was diagnosed younger than 40, then we do different types of imaging at younger ages. But we never really start screening mammogram before age 30. I see. Now, genetic testing is expensive. What would be the argument? Not as much as one would think. And hopefully with economies of scale. Cancer genetic testing right now, full cancer workup genetic testing, cash pay, $250. I guess depends on your point of view, but from my point of view, that sounds like possibly a good investment. About 10 years ago, it used to be about $5,000. $5,000. So there's competition and capitalism at its finest, bringing the cost down. Now, is there an argument to be made that that average person interested in their cat's cancer risk should have one of these panels, or you said 250? Is there any reason other than the cost to not get these tests? The results. Let's say because it can scare you. Yeah. What do you do with having a mutation for sort of an obscure cancer? How likely is it you might then develop that cancer? Yeah, so these are not black and white tests. Nope. Like when you got a blood sugar, you got a number, you know what to do with that usually. But these tests are nuanced. And then some of the cancers that might be associated with some of the genes we don't have screening for.
Right.
So then what do we do with that information?
Right.
And then do we end up doing maybe an invasive procedure? Do we start doing some type of screening and then maybe a biopsy? As you know, biopsies aren't always what we call benign. Sometimes you can do a biopsy and it can cause bleeding or hurt a nerve or another part of the body where then you have to live with the consequences.
In the hospital, you catch C. diff. I mean, it just goes on and on.
And then how does a person, are they ready for those results? What if it says that they have a 50% risk of developing cancer in their lifetime? Does that change how they live their life or what they do? Does it change their mental attitude? How old are they? Are they ready for that information? And so that's where genetic counseling really came in, is to start making sure that if we do these tests, that people are ready for the answers.
You have to be ready. I have a dear friend that has a family history of Huntington's disease. For those that don't know, it's a horrible, fatal, devastating disease, and you don't know you have it until you have it in midlife, and then it's rapid deterioration. And she has elected not to get tested. She doesn't want to know.
And I think that's true of a lot of Huntington's patients.
Yeah.
You know, you look.
It's because if it's positive, what are you going to do? You're just going to be, you know what's coming. You're terrified.
If you knew at 18 you were going to develop ALS.
Right. Difficult.
Yeah. So having genetic testing done is, especially for multi-cancers and for some of the more rare cancers, those that we don't necessarily have strong treatments for, that can be a bit of a danger zone of what do you do with that information? So making sure you're ready for it before it comes back. Depression,
anxiety, these have many, many consequences and collateral damage.
How do you share that information if you have children?
Oh, and your spouse. Oh, my goodness.
But you've got young ones. You know, how would you tell an 8-year-old that, well, there's a 50% chance you have this?
You have it too.
That's not what you want to do. We never recommend testing for most cancers until you're at least 18. But now you have this information that, you know, as a parent, you're kind of not telling your kids, maybe telling your kids. That makes for some rough years depending on your kid.
Yeah, so these are not easy decisions. Genetic counselors can be very helpful, and we have a number of them here in the area. Now, is breast surgery also volume dependent? Surgeons like you that focus on it, that do a lot of these cases, is there any data to say that you're better than the average surgeon who just dabbles?
Data. I think.
Or your opinion. I'll take an opinion.
No, I don't like opinion. There are numbers that we can talk about. So there are numbers and there are satisfaction and there are outcome numbers. The number one number that we have as surgeons is something we call a re-excision rate. So when we do surgery for a lumpectomy.
Okay, that means just taking out just that area.
Just removing the tumor and some normal tissue around it.
Okay.
How often do we have to go back and do a little bit more?
Okay.
That has been shown to need higher rates of radiation when we have to go remove a little bit more tissue. That has been shown to perhaps sometimes delay care, but it certainly increases the cost to the system.
Sure.
If you're paying for 2 elective outpatient operations rather than 1. And that re-excision rate in the world of breast surgery 20 years ago was recognized to easily be 15 to 20%.
Okay.
We've worked on lowering those numbers, but one way you can lower the number is to do a mastectomy, remove the entire breast.
Okay.
Don't know that that's in everybody's best interest to just take more tissue. You can also take a lot of tissue, but then leave the breast maybe not
a wider excision,
looking quite like a natural breast.
Right.
So then trying to find that balance of good cosmetic outcome with nice, good, clean margins without needing to go back and do additional surgery. So that's really where we're heading when it comes for quality for breast surgery.
Okay.
Overall.
Okay. So it is a metric. It can be measured. I'm just going to say, sounds to me like surgeons that do a lot of them like you are going to have better results than those that dabble. It's true in my world of endometriosis. I can tell you that. So, Ann, let's say the woman's had a biopsy, the radiologist has found some cancer, and they're referred to you.
Mm-hmm.
In the old days, it was a mastectomy, radical, but you're doing less and less invasive. You're doing these lumpectomies. I think, are they also called tielectomies or lobectomies? What are there other names for? I know lumpectomy is what everybody recognizes.
Yeah, lumpectomy is what we use kind of colloquially or talking amongst to patients and to nursing staff. The technical name in the medical world is partial mastectomy or segmental mastectomy.
Or segmental is essentially the fancy word for lumpectomy. Okay. So let's say a woman has had abnormal cells. She has some kind of breast cancer. Radiologist is going to refer her to you, right? Now, there's a lot of things you can do nowadays, such as these lumpectomies, and this is an enormous topic. But I looked on your website, and I see you do all kinds of very interesting surgeries. One is a nipple-sparing mastectomy.
Sure.
What is a nipple-sparing mastectomy, and why would you do it?
A nipple-sparing mastectomy is where we remove all of the underlying tissue of the breast.
Okay.
Sort of think of the breast as a little bit of a pillowcase.
Okay.
And we're taking out all the stuffing, but we're leaving the pillowcase behind.
And the nipple keeps a lot of its blood supply?
Keeps its blood supply.
How about the nerves?
So some women, the nerves will travel through where the blood vessels do under the skin to innervate the nipple for both erection or the nipple getting firm.
Okay.
As well as sensation.
Okay.
Others, it travels partway through the breast tissue, and there are some centers currently doing research for nerve-sparing nipple mastectomies.
Oh, I love it.
I have not started that. I don't do that, but they are identifying the nerve running through the breast tissue and then taking the breast tissue around it and saving the nerve.
So you can get the cancer and the glands underneath with good margins safely. Save the nipple and allow you to construct or reconstruct a more natural looking breast.
Yeah, so we take sort of the stuffing out of the pillow and then refill it with an implant.
Now, do you do that or do you bring in a plastic surgeon to work with you? Or?
I have a plastic surgeon who does the implant portion.
So you work together as a team?
Correct.
So you both develop experience with each other and to develop that. And surgery, my friends, is a team effort. It's not just the surgeon, it's the techs, it's the equipment, it's the room.
Whole room of people.
My stereo, I've got to have my stereo in room 6. It's all part of the experience. Now, another thing that you do is an oncoplastic breast reduction. Please enlighten me. What is an oncoplastic breast reduction?
So a breast reduction is a breast reduction. So making the breast smaller, lifting that breast up. When we just add the word oncoplastic, that's because there's cancer involved. So what we're doing is when we're reducing the breast size, we're removing the tumor. So once upon a time, we had breast surgery we had to be oncologically sound. Those are the words and the terminology we use when we're going to remove all of the tumor cells. So way, way back in the day, that was doing radical mastectomies because we knew all of the tumor would be removed. Then we started getting smaller and smaller and smaller.
Right.
But sometimes we still have really big tumors in breasts that need to come out. And if we just removed that tumor and left the rest of the breast there, we'd have sort of an odd-shaped breast.
Sure. Oh, and I got to tell people, breast surgery is so tough to do and have a good cosmetic result. Even the plastic surgeons who do some are way better than others, and sometimes you end up with just a disappointing result. It's very hard to do.
It is. And some of that is because breast surgery comes in the breasts are different densities. It's very different putting fatty tissue together than putting denser tissue together. And so Oncoplastic started to combine the best of oncologic surgery, cancer surgery, with plastic surgery, cosmetic surgery, and putting the two together to get not only a good cancer outcome, but a good cosmetic outcome.
So how could these are called margins when you want to take out a cancer and have enough margin or room around it that you take out the disease and leave the healthy. How do you get a margin in a breast? That must help me on this. I have no idea.
Well, we open up the breast depending upon where we're making those incisions. We know where the tumor is because we've located it through one of a variety of means. If we can only see it on mammogram, then we've had to put a marker in it prior to getting started so we can identify exactly where in the breast that is.
What is a marker? A wire or a dye or ink, or what do you mean?
Usually it's a little metal clip, then sometimes a wire. Sometimes it's a ferrous seed that we use a metal detector to find.
Yeah, what are your gadgets? You've got all these gadgets in room 7, so you have
gadgets.
Yeah, but just go just like you're looking for gold coins on the beach.
It makes sort of a trilly little.
So that's what I hear coming out of your room.
We have 2 different machines that make noises like that.
And doesn't the gamma counter do that?
Gamma,
too?
yeah.
All right, we'll get to that in a second. Okay, so you put in little markers that you can accurately place at the margins between the disease and the healthy tissue.
Yep, and then these little, the trackers that we have, not only do they make the funny noises, but then they actually tell us on the screen how many millimeters away we are.
Oh, wow. So you can really map this out. I just by the way, I just love technology. The ENT folks have a thing on the end of their scope when they're putting the scope in the nose, and they look over on the TV screen, and it tells them exactly where they are. Like it follows them in the computers can tell 3D. So you've got something similar here. So you're able to cut out the disease.
Yep. And then
with your experience, you can what?
Well, then we take the way I do surgery and the way that we've sort of moved things most of the time is then we do what we call shave margins. So we think of like a bowl of Jell-O.
Okay.
With some fruit cocktail in it.
All right.
And there was only one cherry in the fruit cocktail.
Is that the disease?
That's the cancer.
All right, you've got a cherry in the Jell-O. All right.
So you've got this nice, smooth bowl of Jell-O. And you're going to take this really sharp knife, slice right down. And then you can use these really kind of smooth-sided spoons to kind of hold that Jell-O aside.
All right.
And you're going to scoop that cherry out with like a little melon baller. So you get this nice little ball with the cherry.
Oh, my goodness. And that gives you good enough margin. You can be accurate. Oh, no. Okay.
Now you're going to take this really fine, fancy knife, and you're going to do little slices of the Jell-O that were sitting all the way around the edges of the cherry.
And do you send that to the lab in real time?
We send each one of them off. So we take 6 slices, like a dice has 6 sides.
Ah, all dimensions. Okay.
We take one from each side.
Okay.
Then I paint them with some ink.
That's the paint. That's the paint. So you've got this cue. You got up, down, right, left, front, back.
And then we have a little slice from each side of where that cavity was left because we can see it sitting right there. We haven't let the tissue compress back in yet.
Okay.
We take each of those sides out so we don't have any cautery effect. Cautery is one of the instruments we use when we're cutting tissue, and it destroys the tissue right on the edge.
Right, you can't
so
look
if we're
at it.
removing a cancer and that instrument that burned some of the tissue as we took it out destroyed those cells, it could say, no, you have cancer on the edge. That's why we have to take that clean slice right on the edge to make sure that we don't have any cancer cells left.
And is the pathologist waiting for that and we'll look at it in real time?
No.
So they have to. So you finish the surgery.
We finish the surgery and we get those results 2 to 4 days later.
And it'll give you confidence that you have clean margins on those 6 axes, or gee, there's on the purple side on the left inside or whatever has, then would you go back in and shape that further?
We'd have to go back in.
So I know with skin cancer, something called Mohs surgery, perhaps, or you're going to have
Called Mohs.
Mohs, because if you have a melanoma by your eyelid, you can't get a wide margin unless you have to. And so they do these little micro slides. They get a little more, and then they send it to the pathologist. I think they look at it in real time.
They do.
Say, gee, you got it. No, you need to go a little farther, and they can do that in real time.
They do.
Take out as little as you have to get the clean margin.
Yep. So for trivia's sake,
please,
there is one place in the United States that can look at breast margins in real time. One.
And that would be?
Mayo Rochester.
Mayo Rochester. Yeah, here in the Midwest, Mayo is really a go-to place with almost anything. And in fact, if there's tissue, a biopsy, and they're scratching their head, they're not quite sure. Mayo's where you send it. That's where the pathologists that see the rare things live.
But we mentioned before, breast tissue is really fatty. So when you think of how do you look at this, usually when we're looking at tissue immediately, we're doing something called a frozen section. We have to look at that tissue. We have to be able to slice it thin enough to put it under a microscope. So it has to be pretty thin to look at. And with most tissues, we freeze them super cold and then slice them. And what I say when it comes to breast tissue is, for anybody who's ever done some cooking, if you have a frozen chicken breast and you've got that nice solid muscle and you're slicing it real thin so you can get those real thin slices of chicken to do like a stir fry or something.
Yes.
No problem. But when you hit the fat,
oh, it's mush.
Smears it.
Schmears. Schmeckle.
And we can't smear
Schmaltz.
our cancer margin. Because then it would be positive. And the only place, so once upon a time, Mayo Rochester developed the technology to do it. It is so expensive and so time intensive by their residents to do margins that it cannot be replicated anywhere else. And so as a result, we've developed these other techniques. And with that shave margin technique, we've reduced our re-excision rate down to less than 2%.
Whoa. 2%. So I can flip that, reciprocal. 98% of the time you're getting it all with clean margins. Well, that's spectacular. That sounds to me like you got to do a lot of those to get 2%. That's very impressive. So, Ann, another service that I read that you do is that you perform reverse axillary mapping.
Yeah, they got that on the website.
Wow. What is that, please?
All right. Well, we have gotten really good at treating breast cancer, and we have breast cancer survivors who live for a really long time.
Wow.
And one of the side effects that comes from breast cancer treatment is something called lymphedema.
What is that?
Lymphedema is when we get some congestion of our lymphatic system. The lymphatic system runs along with our arteries and veins, and we have collections of lymph nodes at most of our joints and big places in our body. And when we have to remove lymph nodes to look for cancer, we can sometimes disrupt some of the flow of that extra fluid coming from the arm or the breast.
So it has to come back. All of our body, our tissues leak into themselves. It accumulates as lymph and comes back. So the lymphatics can be blocked with these breast surgeries. So what is this reverse axillary mapping all about?
So when we have breast cancer that's gone to the lymph nodes and we know we're going to need to remove lymph nodes, we want to better remove lymph nodes that are specific to the breast and not to the arm.
So they drain just so cancer is less likely to be in the arm node.
Less likely to be in the arm node, but also we have to find out if the lymph node goes to both the breast and the arm, we may have to remove it because it's cancer. So we already do things that we call sentinel lymph node biopsies. We do mapping of the breast lymph nodes, figuring out exactly which lymph nodes are the first lymph nodes in the armpit that drain the breast. Now for reverse axillary mapping, we are putting dye into the arm, a totally different type of dye.
The green?
We use indocyanine green.
Okay.
And it comes up to the axilla And now we can see this one's from the breast, this one's from the arm.
Brilliant.
This one is both. Okay, we have this little tiny channel that we can see because it's bright green, that's lymphatic.
Okay.
We can move that little channel into the nearby vein and help try to reduce the risk of lymphedema developing.
So you are doing a microsurgery.
I'm not doing full, it's called a lympha procedure. And it's not technically microsurgery. It's a little bit of a general surgery abbreviation.
But you're taking a lymphatic vessel and implanting it in the wall of a vein?
We really, the body is an amazing thing. And if we get it close to the little venous tributary,
okay,
it will usually do the rest on its own.
It'll cannulate, it'll find its way out. But you can get it going in that direction reliably. That's astounding. So the goal, which is you can get all the lymph nodes out from the diseased breast and keep some lymphatic drainage from the arm so it doesn't get all doesn't get all swollen up.
So trying to reduce that risk, because there are people doing lymph node transplants at certain centers, true microsurgery, taking a lymph node from the other part of the body, putting it up there to reduce lymphedema. But other than that, yeah. Other than
I haven't even heard of lymph node transplant.
Lymph node transplant, but other than that, we have absolutely zero cure for lymphedema. So we're trying to learn new ways to prevent it from ever happening.
Fascinating. Now, if a woman has a BRCA gene, for example, and very high risk for getting breast cancer and ovarian cancer, and we want to do a risk-reducing procedures, sometimes we'll take the ovaries to lower the chance of them and the tubes. You can also do a prophylactic mastectomy, can't one? Now, do you work with your plastic surgeons to do one of these immediate reconstructions too? So you can take these time bombs off the poor woman's chest and give her a good cosmetic result?
At times. We usually do, it depends on the woman's natural breast shape as to whether or not she's a candidate for us to do what we call direct to implant. So one surgery, do everything, versus a 2-stage surgery.
So 2-stage is also fairly common. How do you do a 2-stage?
2-stage, we do the mastectomy portion. Sometimes
and
we
spare the nipple too?
Sometimes we don't. Sparing the nipple does increase the risk of future breast cancer slightly. The ductal tissue does go all the way up into the nipple, up to the skin. There's just a slight increased risk with that. There are also some women who, by the time they're ready to have breast surgery, they may have had several children. They may have just been born with naturally very large breasts.
Okay.
And the nipple is no longer in a place that no matter what kind of an implant you put behind it, it would no longer be located in the place one would want their nipple.
Where you'd want it. Gotcha. It's gone south.
Yeah.
Okay. All right.
That's not a good one to necessarily keep the nipple on.
Okay, but it's her nipple, but it's going to be a different relocation.
Yeah.
Maybe.
So, or you can do a nipple graft. Those do okay. Most of the time we usually do nipple reconstruction or 3D nipple tattoos.
Gotcha. So depending on the circumstance, saving the nipple may or may not work out.
But 2 stages, we do that, and we do the first stage of reconstruction at that same operation.
Okay.
And that's a tissue expander.
That's like a balloon. You pump it up over time, and it stretches the skin to give room.
Skin to give room. Some ways allows a woman to recover and get a sense of exactly what size she wants to be if she's interested in going smaller or larger.
Gotcha.
And allows the rest of the tissue to heal and then move to permanent implant from there.
Gotcha. Now, are there any other procedures So let me summarize this. The days of radical mastectomy are over.
Correct.
You can get the disease. Now, you can add chemotherapy or radiation. Just give me a thumbnail, a little sketch. When do you use adjunctive or extra radiation? When do you use chemotherapy?
We'll start with radiation first. Radiation is given pretty much for all node-positive disease. So anybody who has positive lymph nodes will get radiation after surgery.
And where does the radiation go?
If you have positive lymph node disease, it'll go across the entire breast or chest. It'll go across the node field, which will be the armpit.
Okay.
We'll also then usually go into the supraclavicular, we call it, or the
Up
area
here.
above your clavicle to your lower neck.
Okay.
And we'll usually cover the breastbone to the internal mammary lymph nodes as
You
well.
get this whole, and what
So
kind of radiation is this?
Comprehensive external beam radiation.
External beam. Are those electrons or protons or neutrons or?
Well, find your radiology oncologist.
I love
I
physics.
think they're protons. I don't know what they are.
Okay, so some kind of radiation, and the goal that is you can kill the sensitive cells of cancer that remain. So, what is the role of chemotherapy then?
Well, I'll go back one step to other radiation. So that's node positive. Lumpectomy
Okay.
for invasive cancer for anyone under the age of 70 is recommended.
Okay, so you got most of it from the surgery.
Anybody having a lumpectomy under 70 with an invasive cancer, lymph node negative, still needs breast radiation.
Because there's some bad actors, there's some potential abnormal cells, and the radiation gets it more reliably, more often.
Kind of clears up the rest of the Ds and reduces the risk of recurrence.
Fantastic. I know you've got very good data on that. Okay, so and I know this, and folks, there's many different types of breast cancer. These are different animals. Some are more differentiated, more amenable to chemotherapy and long-term hormone treatments, and there's some that are more what's called anaplastic or poorly differentiated. Very few things will regulate them. They tend to grow faster and harder to control. And so is that where chemotherapy comes in?
Chemo comes in for really big tumors and more aggressive tumors. So we always, people usually have heard things of a triple negative breast cancer. That's a more aggressive form of breast cancer. It almost always needs chemotherapy, greater than 5 millimeters, and it needs chemotherapy. So even real small ones need chemo.
So I'm gathering you work closely with our medical oncologists
in
the management of these difficult cases.
We all meet, every case. We all meet every Thursday morning, every week.
Uma Ramadas was here a couple months ago. We had a nice chat with him about this. Do you see any advances on the horizon with biotech chemotherapies or drugs? Do you see any revolutionary things coming, or have there been some revolutionary changes in the past 5 years or so?
There have been a ton. The immunotherapies have really, and the CD4K6 inhibitors have really taken off and have shown really good promise in breast cancer.
Are you using them, or they're still experimental?
They're using them now. Yep, we just recently got new approvals, so everything's changing. About every 6 months, we have new rules and new guidelines. It's changing fast.
And you see that's why you need somebody that focuses on this, because who's going to read all these things or be up to date in these rapidly advancing fields such as this? Now, women used to take tamoxifen for years and years. Are women still taking tamoxifen, an estrogen blocker?
Yeah.
Still used a lot?
Tamoxifen, less used. Tamoxifen is used primarily in premenopausal women. But even then, we have a good number. The data shows improvement in ovarian suppression, so using medicines to suppress the ovaries and then adding an aromatase inhibitor over tamoxifen. But tamoxifen is still a big use, can be very helpful in many women.
An old drug, and women take that for years and years. So you're using more of this Femara or letrozole, or
letrozole and anastrozole. So the aromatase inhibitors. Both of those, in general, standard treatment is for 5 years.
Okay.
Some women benefit from longer treatment, and there are tests to run to figure out who's who.
Gotcha. So tell me about this other machine in the OR. That was it, the gamma counter or something?
That's the gamma probe, and that's the sentinel lymph node when we're doing our sentinel lymph
What
nodes.
is a sentinel lymph node, please?
So we mentioned before that there's lymph nodes throughout the body, and we have collections of them. So for breast cancer, our biggest collection of lymph nodes is in the armpit.
Okay.
So an average woman has about 15 to 20 lymph nodes there.
All right.
And when we're looking to see, has cancer traveled from the breast to a lymph node? If there's just a few cancer cells there, 100 or less, honestly, a couple of thousand, we're still not going to be able to feel a big lymph node or even see it on an ultrasound.
That's nothing as far as mass goes.
Yeah. So we need to know, has cancer started to travel? And so what we do is the breast sort of drains this extra fluid, just like all of the fluid circulating through our body.
Okay.
And the breast drains that fluid out of the breast and up into the lymph nodes in the arm and then into the rest of the body.
Okay.
So we inject a special type of dye that's specific to pull into the little lymphatic channels in the body.
Okay.
And we inject that near the central portion of the breast on the day of surgery.
Okay.
That dye is then going to travel up into the armpit, and it's going to go towards those lymph nodes and get stuck in the first lymph node it hits.
And is that the sentinel node?
Those are the sentinel nodes.
Okay, so it could be plural. It's not one necessarily.
Most common is 1.
Okay.
Up to 3 is pretty typical. Never more than 6.
Okay. So and is that where the gamma rays are?
And that's where it's in technetium 99. We're injecting a radioactive nucleocolloid. So the little dye that we inject emits this signal that we can pick up with our little
probe.
Geiger counter.
Geiger counter, right.
Yeah.
So you can find that sentinel node, take out that sentinel node, and if you're very specific, the other lymphatics from the arm are undamaged, hopefully.
Mm-hmm.
So it allows better mapping and whatnot. Now, is there any other really cool procedure you do nowadays, or something you do as a specialist that someone might not get elsewhere? But certainly standard of care, you're on the cutting edge. You do all the cutting edge procedures. So somebody in our area, if they go to you, they're going to get some of the best care in the world, aren't they?
I hope so.
That's my goal. I know so, Ann, because I know you really, really care about your patients. Now, I know women are always it must be terrifying to have a mass and to go into this. Are there any stories or words of comfort or advice or that you can give to women who might be facing going into this, into going in to see you?
Unfortunately, breast cancer is really, really common. One of the good things about this breast cancer being as common as it is that there has been so much money and energy and research directed towards breast cancer that most breast cancer is curable.
All right, let me repeat that. Most breast cancer is curable.
Correct.
And obviously catching it earlier is better than later?
Catching it earlier is better than later. Absolutely. And there are times that women do everything they can to try to catch it early, and still it kind of slips through and does its cancer thing and misbehaves and becomes really aggressive. But the majority of breast cancer is curable. And so if we get onto it and use our standard treatments and get from point A to point B, most women are going to do very, very well with cancer treatment.
Fantastic. Well, Ann, I want to thank you for taking the time in your busy schedule to come talk to us about breast cancer, how you treat breast cancer, the advances in the treatment of breast cancer, and the very optimistic statement that most of these diseases are treatable. So I want to say it's really a pleasure having you as a colleague. I'm glad to call you my friend. I want to tell everybody that your patients love you. I hear wonderful things and wonderful reports about you. And I really appreciate all you add to our community. Thank you very much.
Thank you.
What a pleasure talking to you.
Appreciate you having me here.